I think that education and support are a key component of the care that we all need to be providing. But I think there's definitely some differences of opinion on how we do that, how much information we give people at the beginning versus information we give them along the way. And again, that's one of the conversations in this symposium. If we know, for example, in general, what the course of MS is likely to be, if we know the comorbidities that can complicate people's lives and actually shorten life for people with MS, if we know what advanced disease is likely to look like for one person or another, how much of that do we tell them? And when do we start talking about it? Is it too scary and so we shouldn't talk about it until they're already there? Or by talking about it early and providing education, are we helping them to hope for the best, but be more prepared for the worst in terms of life planning, preventive health care strategies, being very active and adherent with their DMTs, and generally creating as many safety nets for themselves, physical, emotional, financial, as they possibly can. And I think when we talk to the people in the room, we're going to get differences of opinion about how we do that. I think the beauty of the Consortium of MS Centers from its inception is its commitment to the idea that good care for people affected by MS has to be integrated, has to be comprehensive and interdisciplinary. We can each do a good job in our own sphere, but without communicating with one another and helping patients and families utilize the full team and communicate with the full team, we're missing the bet. This is a disease that can't be managed by any single practitioner alone. So it's our responsibility to teach patients about comprehensive care, and it's our responsibility to behave in that integrated fashion so that we can ensure the best care for people with MS. I think it's essential for people who are diagnosed with MS and family members to know that there is a significant risk of mood changes with the disease. We now know that depression is one of the most common symptoms of MS. It's not just a reaction to the challenges of living with the disease. Providing that education from day one, I think, is critically helpful, because some people who've never been depressed in their lives or experienced that feeling may suddenly experience shifts in their mood and they don't know where they're coming from or what's causing them, but they know that there's a lot of stigma attached to those mental health changes in our culture, unfortunately. And so by normalizing how common mood changes are in MS and alerting individuals and family members to the possibility that they're occurring, I think we make it a lot easier for people to recognize them, to report them to their healthcare provider, to access treatment in the same way they would for any other symptom of MS, because this is not a reflection on their moral character or their strength or their ability to face challenges. It's simply a symptom that needs to be treated. So I think that sets the groundwork for working together on managing the challenges of the disease, dealing with mood changes as part of that comprehensive care of MS. And I think that as long as we're there partnering with our patients and willing to hear them talk through their feelings, treating depression if and when it arises, but also recognizing that people need to be able to talk out loud about the quality of their life and choices they make about end of life, and respecting individual decision making, I think that alone is so reassuring to people, that they can talk about these things without being condemned for having thoughts about, is my life what I want it to be now? Is my quality of life worth living? It's just our responsibility to make sure that people are never making decisions about their lives when they're depressed, because people can't make effective decisions when they're depressed. We have to be there to ensure that if depression is what's driving the conversation, that we're treating it. I'm very excited about the symposium we're doing on depression and mood changes here at CMSC, because we're bringing together experts in mood changes as well as an expert on suicide and suicide prevention to talk about just that. We know that the risk of suicide in MS is significantly higher than the general population, and higher than in a lot of other chronic illnesses. And I think it's because depression is so common in MS and it's under-recognized and under-treated. I think once a person is depressed, they're depressed and they need to be treated, and it doesn't matter whether they have MS or not. We still don't know whether the depression phenotype in MS is exactly the same as the depression phenotype in the general population, or if it's different. But until we have that answer, we know that people respond to antidepressant medication. We know that a lot of the symptoms are the same whether the person has MS or not and is depressed. And so I think we just need to be vigilant in educating, and we need to be very careful not to fall into the trap of thinking, well, the person has a chronic unpredictable illness and is living with a lot of disability, so of course he's depressed, or of course she's depressed. Who wouldn't be? And we need to make sure that individuals and families don't fall into that trap, because that's what keeps us from doing what we need to do to ensure that they get appropriate treatment.